Hi, this is Bedrest Coach Darline Turner-Lee, owner and founder of Mamas on Bedrest and Beyond. Today, I want to talk a little bit more about the ever ongoing struggle of whether or not babies should be birthed by OBs, by midwives, in hospitals, at home. I mean, it's a question that just keeps coming up, and it's one that I keep addressing because I really think women need to have options. Whether we're high risk, low risk, whatever, you ought to be able to choose when and how you birth your baby. I follow a lot of different organizations online, and I recently, like yesterday, I think, got this press release from the Push for Midwives. And rather than me trying to paraphrase or anything, it's pretty short, so I'm just going to go ahead and read it, and then I'm going to give a couple of comments on it. And it's entitled CDC Finds a Continued Increase in Home Births. Report highlights disparities in access for women of color. And that's just a pet peeve of mine for obvious reasons. And it goes on, Washington, D.C., January 26, 2012. A report released by the CDC today found a 29% increase in home births from 2004 to 2009. The rate of home births among non-Hispanic white women underwent a dramatic increase, while the rate for women of color decreased or remained stagnant, a trend that reflects racial and ethnic disparities in other areas of maternity care throughout the U.S. Unfortunately, the women who can most benefit from out-of-hospital midwifery care are those who are least likely to have access to certified professional midwives with the specialized training needed to provide it, said Susan Jenkins, legal counsel for the Big Push for Midwives Campaign. The CDC report and other research shows that babies born to women cared for by certified professional midwives are far less likely to be preterm or low birth weight, two of the primary contributing factors not only to infant mortality, but to racial and ethnic disparities in birth outcomes. Barriers to out-of-hospital maternity care include laws in 23 states, the District of Columbia, and Puerto Rico that prohibit certified professional midwives from practicing, as well as laws or policies in all but 11 of the remaining states that deny Medicaid coverage for home births managed by certified professional midwives. As we work to address these disparities by increasing the cultural proficiency of midwives practicing in and out of hospital settings and diversifying the midwifery workforce, we also need to change laws nationwide so that all women have access to out-of-hospital maternity care with certified professional midwives, Jenkins said. Anyway, let's really kind of look at what's going on. I mean, there is an increasing trend towards women having their babies in settings other than hospitals. There's birthing centers, and yes, the increase in home births. I mean, I'm kind of on the fence about this because I know for myself, it would have been a disastrous nightmare if I had tried to have my children at home. I'd probably be dead. But for women who have uncomplicated pregnancies and there's no contraindication, I'm still kind of wondering why can't they decide where they want to have babies and who they want to deliver their babies. But be that as it may, one of the things that is increasingly disturbing to me about this whole, doctor, midwife, home, hospital debate is the fact that when it comes to women of color, and in particular women of color who are of low socioeconomic status, i.e. don't have money, it becomes, how do I want to say this? It becomes an issue of, okay, we don't want to give you the great care because you don't have any money, you're not insured, so you end up in some maybe, what do we used to call it in PA school? There was a term for it that was really kind of insulting because people had no money and they had to go to certain hospitals and things. And the point being that if midwives are willing to treat these women and care for them, why can't they go and see these professionals and have, quality care, and more importantly, care from people who care for them? I'm not saying that all doctors are bad. That's not true. Every profession has its good people and their not so good people. But by and large, when we're dealing with reimbursement in particular, providers are far less likely to provide the wide range of care and options and things when they know reimbursement is going to be limited. it's the bottom line. It's the truth. We don't want to admit it, but in the U.S., money talks, and that's how it goes. So if, you know, say for example, where I went to school, Duke University, if they don't want to have a lot of Medicaid patients or treat a lot of Medicaid patients or go through the prolonged birth and this, that, the other thing, not saying that they do, I'm just taking it as an example. So Duke, please don't come and start suing me. If, for example, that is the case, then why can't we then say, okay, let's hire or somehow contract with midwives who want to do the out-of-hospital births, who are skilled at working with women from very early on and bringing them through, talking to them about nutrition, talking about the importance of prenatal care, doing things like centering pregnancy, and all of these different things, and who basically, let's just really talk about it, ask for, not ask for, but do their services at a lower cost of reimbursement. Why not contract with them? We're having so many different arguments in Congress right now about, healthcare and how much it's killing our economy and this and that. If we have proven methods like Jenny Joseph, who I interviewed on December 16th, you can listen to that podcast, talked about having a whole system of addressing pregnant women early on, fifth and sixth weeks of gestation, when they're just learning that they're pregnant, letting them come in, talking to them about nutrition, managing their weight, sleep, stress, addressing their questions and problems. This is not what happens in obstetrical care. If you go to the hospital to doctors, you don't go into weeks 9 through 12. So they're getting an early jump, and it has been shown with Jenny Joseph, as well as Shafia Monroe with her International Center for Traditional Childbearing, that starting earlier and really sitting down and explaining to women and talking to women and letting them know, this is really critical for your well-being, as well as addressing their questions and concerns, their outcomes are better. I mean, they have documented data. Their outcomes are better. Now, the CDC is showing outcomes are better. More women are having babies at home, and it's going well. And it says right here, the CDC report and other research shows that babies born to women cared for by certified professional midwives are far less likely to be preterm or low birth weight. In the African American community especially, I can't speak as much to the Hispanic, and I will try and get some of those numbers, but in the African American community, it's rampant. The children are born early, they're born low birth weight, they have a lot of medical problems at times, all because they don't get, sometimes their mothers don't get adequate prenatal care. Again, if this is a way to provide it, why not? If midwives, certified professional midwives, are willing to provide this care, why not let it happen? Why are we having this argument? I mean, as the powers that be keep arguing, midwives, doctors, OBs, midwives, in hospital, out of hospital, the women are sitting here just kind of waiting, wanting to have their babies, wanting to have healthy babies, wanting to do what's best, and really not knowing. And in the crossfire, if you will, those are the people, the moms and the babies, that are losing. A lot of people are probably thinking, why is she always talking about this? She's supposed to be talking about mamas on bed rest, blah, 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 blah. One, I was in that realm. I actually had great insurance. We had PPO, it was wonderful. I still had a low birth weight baby. My daughter was preterm. She's 5 pounds, 3 ounces. What's up with that? We know these different disparities happen. I went for early prenatal care, but it is what it is. We know in the U.S. culture, African American women don't do as well for a variety of reasons. But if we have something here that shows that they can actually do better, why not implement it? We know our maternal mortality rate in this country is worse than most other industrialized nations, and whatever that one number is, I think it's 13 per 100,000 or whatever. It's 4 times greater for African American women, yet these are the women who don't have access to any types of options. So I'm hoping, one, I wanted to read this because I want people to know and to understand there are things out there that can be done. We can't all sit here and go, oh man, our maternal mortality rate's so bad. No, things are so bad, and it's horrible for women of color, and it's horrible for women without means. And right now it is, but that's not to say that there aren't things that can be done. This, press release with the study report released by the CDC shows there are things that can be done. Jenny Joseph, in her interview, please go back and hear it because she's done some phenomenal work, has shown in her own practice how she's been able to lower adverse birth outcomes by simple, really just good prenatal care. And Shafia Monroe has done the same thing, and we are going to see if we can get her on here and talk about, what she has done to implement, really mother and child-friendly care, but with a cultural aspect, because I think we have to be aware that sometimes going to the hospital, not sometimes, anytime you go to the hospital, it's a frightening thing. It's just big, and there are whole lots of sounds and things going on that most garden variety people like us, we don't get it. We don't understand. It's scary. Couple that with the fact that you may not be feeling well. If you're pregnant and you're in preterm labor and you know it's not time for your baby, so you're scared. All this stuff is coming up. And then let's add to that, you might not speak the language. Or let's add to that, people may be looking at you because you're different, or, I've talked to several women who say, they looked at me kind of like I was scum because they knew I was, a single mom and I was on Medicaid. That shouldn't happen. It shouldn't happen, and yet it does. And people say, oh, you bring up the race card. Now, I'll bring it up because it happened to me. When I went in to have my son in 2006, we're not talking about a long time ago, in 2006, I think I was day one post-op because I had a C-section, and I'm changing him and kind of playing with him and everything. And this social worker, she comes in and she's like, hi, and how are you? How's everything going? Fine. And she gives me this big binder for WIC and Medicare, and I'm looking at her like, what is this? And she's like, well, just some resources so that when you get home, you'll have all the information that you need. Now, being the little wise ass that I tend to be, I started playing with her like, oh, and do you make this call to all of your patients on the floor? Well, I just thought you may need some extra. And I said, oh, and why is that? Why is it that I would need this extra information about Medicare and about WIC? And she really had no idea, except that at that time I was the only African-American woman on the floor in the hospital. And so she came right on in because she assumed that, I don't know if she assumed I was married or not, but she obviously didn't look at my chart because she was seeing that I was married, that my husband had a great job. We had private insurance, and the materials she was providing for me were a moot point. But these are the types of things that happen in our hospitals and in our birthing centers. And, people talk about, well, why are the numbers so bad? I mean, I sort of joke about this, but it's really not funny. And the fact that I can remember it some 6 years later tells me that it hit me on some other level that I hadn't really contemplated. But if you're feeling like everybody's judging you where you are supposed to be cared for, but they're judging you and kind of like, oh, well, if she weren't so overweight, maybe this wouldn't have happened, or if she didn't have, 3 babies by 3 different men, this wouldn't be. If you're feeling that judgment, you're not going to really want to roll in there and get care. I mean, that's the long and the short of it. If you're not going to go somewhere and get good prenatal care and you show up later, that's more time that's gone by to have complications that aren't addressed early on. And the whole thing really just rolls downhill. We need to have cultural competency, regardless of what you may feel or think of women who have babies out of wedlock, whatever. If you're a provider, you have to put that aside and really focus on the mama and make sure she gets what she needs. Again, Shafia Monroe with her International Center for Traditional Childbearing, with Jenny Joseph, and with several other groups, they're starting to do that. I know there are some Latino groups that are doing the same thing because we're realizing that we have to step in and start saying, this is the type of care we need. We need certified professional midwives of colors, all colors, not just, Black, not just Hispanic, not just Asian, Indian, what have you, of all colors, so that women of all ethnicities and cultures will feel comfortable having their babies. But, even before that, feel comfortable talking with their providers about things that are going on. I mean, if a woman's being battered and she doesn't feel like she can talk to her provider about it, that's a problem. If she's, not having enough money for food, or, doesn't have a job, isn't sure how she's going to make rent, these are problems that are going to impact her pregnancy. And our current healthcare system, our current obstetrical system, and again, it's not every obstetrician, but a lot of times doesn't make it a safe place to talk about these things, because it's, your baby's fine, go home, I'll see you in a month. Well, the baby's fine, mama's not. So if mama's not fine, the baby's really not fine. And that, I think, really speaks to what's kind of going on with midwifery, that kind of global addressing of all these different issues. Again, not to say that obstetricians don't address these issues, but not in the same way and not with the same frequency, and not if they have to see 45 patients in a day. Can't do it. There's no time. I hope that more of these reports will come out. I hope the Centers for Disease Control and Prevention will start to speak with powers that be, the AMA, ACOG, and others, and really start taking this to heart and saying, look, for complicated pregnancies, yeah, maybe we're best, maybe we'll do this, what have you. In uncomplicated pregnancies, and in pregnancies that have the potential not to be complicated, let's try and implement some of these other measures. And by that, working with midwives. It's what needs to happen. It's what needs to happen for mamas on bed rest, because we need doulas. We need people at home to help us while we're on bed rest. We need people who can interface with us if we're in the hospital with our families to make sure that things are getting done. That's not covered in obstetrical care. It's just not. It's go home, go on bed rest, or go to hospital, you're admitted. You have kids, oops, sorry. You have a job, well, you're going to have to talk to your employer, and we all know it's just a big fat mess. So again, let's see if we can work this together. Let's see if we can kind of bring this together. It would be great if we could change some of these laws, laws in 23 states, District of Columbia and Puerto Rico, that prohibit midwives from even practicing. I mean, those are 23 states of women, and 2, other U.S. properties, or whatever you call them, District of Columbia and Puerto Rico, where women aren't having access to care. And then 11 states that severely limit or prohibit midwives from practicing or being covered by Medicaid. I mean, it's kind of hard to practice when you're not getting paid, because then you become indigent. That's the word I was trying to remember. Indigent patients, they don't have money. So how is that? How is that beneficial? I hope that for those of you listening aren't going, oh, she's ranting again, blah, 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 blah. This is important. We have to speak up. We mamas, whether you're on bed rest, have been on bed rest, may go on bed rest, whatever, we have to speak up, and we have to speak to our legislators, people in the CDC, write them, call them, tweet about it, whatever. But we have to say, we want mother-friendly care. We want access to mother-friendly care. And it shouldn't be predicated on whether or not you have money. It's a sad commentary, but so many reports and things are coming out about how poor maternal care is in the United States. I just did another blog post about it from was a guest post from Medical Billing and Coding that they shared with me. But the top 10 countries in the world for maternity care, the U.S. wasn't even close. So I mean, let's look at this. It's beyond just a doctor midwife thing. It's beyond a hospital home birth thing. It's really about moms and babies. We need to take care of moms and babies and make sure that everyone comes through childbearing safely. And we need to use both doctors and midwives, and they need to start working together. So anyway, that is what I wanted to share with you today. Let's hope we can begin to work together more. Let's hope that now that the CDC is looking at this, they can kind of give a little to the situation and say, look, people, let's stop arguing, and let's see how we can work together to make childbearing safe in the U.S. Let's not be like, what is the report, Amnesty International? It's, dangerous to have babies in the U.S. I mean, that's kind of a scary moniker, but it's not all entirely untrue. Let's see what we can do. And for you mamas on bed rest who may be listening to this, who may see this, who may feel like, oh, this doesn't pertain to me, it really does, because if you don't feel like you can get good maternity care, if you don't feel safe, if you don't feel like you can get all your questions answered and your issues addressed, you're not going to have good care, which could then lead to a poor outcome. So that's all I'm going to say on this. We're going to keep going. We're going to keep talking about it. We're going to keep pushing. Push for Midwives is pushing. Mamas on Bed Rest is out there. Working Mother, NARAL, National Partnership on Women and Families. It's important. We need to take care of our moms and our babies. So join with us. You can put a comment on this. We'd love to hear from you. Please comment and share. Talk to your congresspeople. Talk to your legislators. Talk to your council people. Get involved. I mean, some people may think, well, I've already had my babies. Well, do you have children? I have a daughter. I mean, she's 9 now, but at some point she'll probably have a child. I have a son. One day he'll have a wife, I hope, and have a child. I want them to have good care. So it's not just about me. It's not about, well, I'm done. No, I'm not done. My children aren't done. And their children aren't done. And, so on and so on and so on. It needs to be addressed. So thank you for listening. Please share your input. Please share this podcast. And if nothing else, have the discussion. Talk to your friends about it. What do you think about that? Would you have your baby at home? Keep the discussion going, because it's the only way we're going to come to some sort of consensus and start making some inroads and making some changes that will benefit mothers and babies. I'm Darline Turner-Lee, Bedrest Coach, owner and founder of Mamas on Bedrest and Beyond. Thank you for joining me. Let's try that again. Darline Turner-Lee, Bedrest Coach, owner and founder of Mamas on Bedrest and Beyond. Thanks for joining me today, and I hope to hear from you soon. Thanks.